Okay, so I'll be talking about AMD terminologies. Uh, Now, OCT, as Dr. Neha mentioned, has revolutionized the retina practice for last 2 decades. It has discovered several new diseases and things which we never saw earlier and now easily visible. And it's now the single most important imaging modality which is available to us. Uh, Over the time, it has become high resolution. Earlier, it was spectral domain, and now we are using swept source OCT. It provides us optical biopsy at micron levels. Now, why we are discussing all these nomenclatures? The aim of the nomenclature and uniform nomenclature and terminologies is to make the existing terminologies uniform, so that the same thing is not pronounced with two different names and we can understand the diseases better. In the short term, they may appear a little bit confusing, but they are useful in the long term and help in spreading medical education. Now, as Dr. Neha mentioned, one of the consensus meeting we heard was about the nomenclature of the terms on the normal OCT. But over a period of time, once the nomenclature has been fixed for the normal OCTs and normal population, uh, there have been consensus meeting happening which decide the uniform terminologies for different set of conditions. We have two such in AMD as well. The one which is used for the dry AMD is known as classification of the atrophy meetings, which I'll be referring to as now CAMS. And there is consensus on the non-neovascular AMD nomenclature as well, which I'll be referring to as CONAN also. Now, CAMS we predominantly uh, covers the dry or the non-neovascular AMD, what we refer to as geographic atrophy previously. Now, previously, predominantly geographic atrophy was decided on the basis of color photographs. It was defined as an area of 175 microns or more, which was well defined and through which we could have visible choroidal vessels. But even if we use FAF, which is now the gold standard for measuring atrophy, there are limitations. And with OCT, we know that the outer retinal atrophy, at least in certain scenarios, may precede the retinal pigment epithelium atrophy. And that's why we have the need of uh, CAMS or the classification of atrophy meetings for dry AMD. So let's talk about the CAMS nomenclature first. As opposed to the earlier definition of AREDS, the CAMS believe that 250 microns is a decent number for considering that area of atrophy, and one must not have any RP tier to apply one of these terms. Now, the terms they have described is retinal atrophy or the retinal and retinal pigment epithelial atrophy. So when there is only retinal atrophy, it is known as outer retinal atrophy, which can be incomplete or complete. And when you have retinal and retinal pigment epithelium atrophy, it is known as incomplete retinal and retinal pigment epithelium atrophy, which can be incomplete or complete. Now, there is not as yet the definitions of all of them which are available, but what has been finalized is the definition of complete retinal and retinal pigment epithelium atrophy, which is known as complete RORA. Now, this is one such example. If you see, this is the OCT, and on OCT, if you see, retinal pigment epithelium is gone. So are the outer retinal layers in terms of EZ as well as IZ. And if you see, outer retinal layers are sagging into this area. This is what is known as the subsidence sign. And if you see, there is uniform posterior transmission. And on AF, if you see, these areas are seen as totally black. Another such patient where you see complete RORA. Now, authors have given their images in their prototype images in their articles. This is, as I've shown, complete RORA, where you have atrophy of the retina as well as retinal pigment epithelium. There's totally uh, total atrophy of the outer retinal layers, and there is homogeneous transmission into the choroid. But in cases of incomplete RORA, what happens is that RP is not gone totally. So some bit of RP is still preserved, as you can see here. The RP is preserved, but in some places, but other places the RP is gone, and what it results is inhomogeneous transmission of the choroid. Then we come to outer retinal atrophy, which can be complete and incomplete. In both these conditions, the RP is totally intact, while in incomplete outer retinal atrophy, some of the EZ and IZ is visible. In complete outer retinal atrophy, none of the EZ or IZ and ELM is visible. So that is what is the current standard now, and what is being followed for the nomenclature of the atrophy in AMD. Now, what is the importance of these uh, terms? There are studies which are ongoing, which are evaluating various agents which prevent geographic atrophy. Uh, Now, when we were using the previous standards, that is color images and the autofluorescence, with those modalities we were recruiting the patients where already complete geographic atrophy or the complete RORA has happened. Now these are the patients which are very unlikely to improve with the current standards, so we must recruit those patients who have incomplete atrophy, and that is why we have introduced these terminologies, so that the patients with early atrophy can be recruited and we can assess the effect of these agents which prevent geographic or the retinal and outer retinal atrophy. Now, the second reason why this is important, that with OCT, we know that at least in a certain subset of patients, the outer retinal atrophy precedes the RP atrophy, and especially in patients with subretinal drusenoid deposits. Now, what are these subretinal drusenoid deposits? Now, typically, drusen are seen in the sub-RP space, but these subretinal drusenoid deposits, which were earlier known as pseudodrusen, are seen in the space which is beneath the retina and above the retinal pigment epithelium. These can be of nodular type or of the ribbons type. So, if you see, these are the ribbon type subretinal drusenoid deposits, while these are nodular deposits, and these are very well seen on autofluorescence as well as near infrared reflectance images, where they are seen as target lesions which are bright in the center and dark in the periphery. Now, these are typically can be associated with other drusen type and typically soft drusen. If you see, these are the nodular subretinal drusenoid deposits which are associated with soft drusens and drusenoid PEDs. So on OCT, if you see, these are the subretinal drusenoid deposits which are there above the RP. Now, what is the significance of these SDDs? One, they are independent predictor of retinal RP and geographic atrophy of the retina. They can have a very high incidence with association with RAP or something known as type 3 neovascularization now, and they tend to be associated with thin choroid and high risk of advanced AMD. Now, from India, there is very limited literature available on it, and we have recently published clinical and multimodal imaging modalities, features of subretinal drusenoid deposits. Coming to the next set of terminology, something known as outer retinal tubulation. Now, these are nothing but hyporeflective uh, lumen and hyperreflective margins. So these lesions are typically seen in outer nuclear layer, and several subtypes have also been described. These can be seen in either neovascular AMD, or they can be seen even in non-neovascular AMD. And of late, we have seen that they are present in several kind of dystrophies as well. What is the clinical significance? They indicate that the disease is already advanced, and basically they indicate a kind of healing response by the photoreceptors and indicate a poor prognosis. Now, these are some of the images. If you see, this is a complete outer retinal tubulation which is present in a case of subretinal fibrosis. This is a patient with incomplete outer retinal tubulation, which is associated with advanced type 2 neovascularization, which is associated with some bit of intraretinal fluid, and they can be present where they have some bit of hyperreflective deposits inside them. But one thing must be careful is about this particular entity. If you see, this is what looks like a outer retinal tubulation, but is present in the inner retina. And if you see corresponding FA, it is nothing but a microaneurysm. So you must remember that outer retinal tubulations are seen in the outer nuclear layer and not in the inner retina. Coming to neovascular AMD terminologies, now most of them are we are already using. What we refer to as occult CNVM earlier is now known as type 1 CNVM. The classical CNVM, which was above the RP, is now referred to as type 2 CNVM, and the intraretinal CNV or the RAP is now known as type 3. When you have a combination of these, which we earlier known as minimum classic, is now known termed as mixed CNVM. Some other pathologies, some other terminology which have come up new is known as SHRM or subretinal hyperreflective material. Now, let's have a look at one of these patients. This is a patient with neovascular AMD as visible on FA. You see stippled hyperfluorescence in the early phases, which increases in the late phase, and you see a well-defined membrane on the ICG. When we do an OCT in these patients, but you see that this is a type 1 CNVM, and when you do OCT, there is kind of hyperreflective material which is there in the subretinal space, which is visible in several of the OCT scans. And if you do autofluorescence in these patients, we see that there's no hyper autofluorescence corresponding to these lesions. Now, that is what is known as subretinal hyperreflective material. It can extend into the retina or it lies underneath the retina. And as per the current definition, it includes everything except blood. Now, how do we distinguish it from vitelliform material? Because it is hypoautofluorescence as opposed to vitelliform material, which is hyperautofluorescence. It can be a mixture of serum, fibrin, or inflammatory cells. And the clinical significance is that it can resolve with anti-VEGF therapy, but when it resolves, it leads to fibrosis, and hence it indicates a poor prognosis in a patient who possesses it in the beginning. The next sign, something known as onion sign, it is clinically seen as something similar to hard exudates, but it tends to be deeper, a yellow material in the sub-RP space. And when you do a OCT through it, what you get is onion peel-like linear hyperreflective bands. Now, some people believe that it is nothing but sub-RP lipid, and over a period of time with treatment it tends to resolve, though very slowly. Now, a corresponding terminology which has come up recently is something known as multi-layered PT. Now, you must not confuse multi-layered PED with the earlier described onion sign. Now, the onion sign would be visible clinically as yellow hyperreflective material, but multi-layered PEDs would not be seen clinically. They would be seen only on OCT, and they constitute nothing but hyperreflective linear bands which are present beneath the PEDs. And typically they are seen in vascular PEDs, and now we term them as multi-layered PEDs. At times, with the anti-VEGF therapy, what happens is they tend to contract and they separate. And in between them, what is left is something known as choroidal cleft, which is a hyperreflective space. Now, why they are important? These are represent a very dramatic appearance, and surprisingly, these eyes tend to maintain a very good visual acuity. The why? Basically because the cicatricial process is confined to the sub-RP space. These prechoidal uh, clefts have been shown in approximately 10% of the eyes with typical neovascular AMD, but they are more common in type 3 neovascularization. They are associated with poor visual outcome, especially if they develop within 6 months of the treatment. Now, this is again a newer terminology which has come up recently. Now, you see, this is a typical Drusenoid PED, which is visible on OCT as well. They tend to be hyperautofluorescence. And if you see carefully in this particular picture, there's some hyper reflective material overlying this PED, which is going into the retina. Now, this patient, if you carefully see over a period of time, this PED tends to flatten a bit, and these hyper reflective materials gradually inch towards the inner retina. Now, this is something what has been referred to as brucellose, and this is one of the proposed hypotheses that these Drusenoid materials slowly ooze into the inner retina, and these lead to regression of the Drusenoid PD, which over a period of time can lead to atrophy of the outer retina. So to sum up, terminologies keep changing over a period of time. With evolving technology, they help us provide a better understanding of the disease progress, and one must be aware about them, as they help in the uniform nomenclature and better describe the disease process. Thank you very much.